Hello everyone. Welcome to the RSNA Radiographics Podcast. This is Lisa Blacklock and I'm a nuclear radiologist from the University of New Mexico. We'll be discussing a recent radiographics article about dopamine transporter imaging. It's entitled Practical Overview of I-123I-Ioflupane Imaging in Parkinsonian Syndromes by Dr. Mercer and colleagues. This article provides an overview of dopamine transporter imaging and its role in distinguishing Parkinsonian syndromes from other clinical mimics. The article provides background information on the pathophysiology of Parkinsonian syndromes and on the importance of correct diagnosis. It also provides practical information on imaging, interpretation, reporting, and pitfalls. As a brief overview, here are some of the major points of the article. First, dopamine transporter SPECT imaging can cost-effectively improve diagnostic accuracy, and it can change patient management and improve patient and provider confidence in the diagnosis. Second, a normal examination shows bilateral, symmetric, comma-shaped activity overlying the striata, and these two regions of activity should be intense and distinct in comparison with background brain parenchymal activity. Third, since approximately 50 to 60% of dopaminergic neurons are lost in patients with symptoms, the imaging findings in symptomatic patients with Parkinson's disease are generally not subtle. Fourth, abnormal studies show decreased uptake, and this can be either asymmetric or symmetric. Initially, activity loss typically affects the putamen posteriorly, and this results in an ovoid or round region of activity instead of the normal comma-shaped activity. With disease progression, activity loss within the anterior putamen and the caudate can also be seen. Additionally, potential pitfalls or issues confounding interpretation include motion artifact, poor patient positioning, scaling issues, off-peak acquisition, and prior cerebral infarcts. Parkinsonian syndromes are a group of neurodegenerative disorders that include idiopathic Parkinson disease, and other entities collectively known as atypical Parkinsonism or Parkinson plus syndromes. Parkinson plus syndromes include dementia with Lewy bodies, Parkinsonian type multiple system atrophy, progressive supranuclear palsy, and corticobasal degeneration. These entities are characterized by degeneration of the dopaminergic pathways and a deficiency of striatal dopamine. And there's an associated decrease in activity on dopamine transporter imaging. Degeneration of dopaminergic neurons in the basal ganglia results in motor symptoms, and these can include tremor, balance issues, bradykinesia, and rigidity. Although classic cases can be diagnosed clinically, the diagnosis may not always be clinically apparent, particularly in the early stages of disease. In unclear cases, dopamine transporter imaging may be helpful. I-123I-Ioflupane was initially approved by the US FDA in 2011 for differentiation of essential tremor and Parkinsonian tremor. In 2022, this clinical approval was expanded to include adults with suspected dementia with Lewy bodies. Ioflupane is a cocaine analog that binds with high affinity to the presynaptic dopamine transporters in the striatum. This was initially classified as a Schedule II controlled substance, but due to the small administered dose, was found to be without pharmacologic effects. The manufacturer provides a list of medications that can interfere with dopamine transporter imaging and recommendations for holding periods prior to the study. Examples include cocaine and ephedrine, and this information is summarized in the article. On the day of this study, approximately 1 hour prior to administration of the radiopharmaceutical, the patient is pre-medicated for thyroid protection. Lugol solution or oral potassium iodide may be used for this purpose. 1 hour after the pre-medication, the I-123I-Ioflupane is administered via slow IV injection. SPECT or SPECT-CT imaging is performed approximately 3 to 6 hours after injection. During imaging, it's recommended that the patient's head be placed in a headrest, with steps taken to minimize motion. Sensitivity and specificity of imaging has been shown to be greater than 90% in multiple studies. Interpretation of dopamine transporter SPECT or SPECT-CT is often possible qualitatively, with review of the images for the expected bilateral, comma-shaped regions of activity over the striata, and for the expected intense and distinct activity in comparison to background parenchyma. Abnormalities can be either symmetric or asymmetric, and typically, in Parkinson's disease, abnormalities are not subtle, since a significant portion of the dopaminergic neurons are lost in symptomatic patients. Generally, in patients with Parkinson's disease, initial activity loss is noted in the posterior putamen. Later, abnormalities can be seen in the anterior putamen and the caudate, as activity loss progresses from posterior to anterior. With loss of this posterior activity, the expected comma-shaped configuration generally becomes more oval or round in appearance. Semi-quantitative software interpretation may be used to supplement visual interpretation. Abnormal study results can be seen with Parkinson's disease and with other Parkinson plus syndromes, including corticobasal degeneration, dementia with Lewy bodies, Parkinsonian type multiple system atrophy, and primary supranuclear palsy. On the other hand, normal study results would be expected in patients with essential, psychogenic, or drug-induced tremors, and in patients with Alzheimer's disease. Although the interpretation criteria is relatively straightforward, it's important to note that the posterior to anterior pattern of loss may not occur in patients with Parkinson plus syndromes, and that findings in these patients may be more subtle. In addition, there are potential pitfalls that can cause an abnormal appearing study. These pitfalls include motion artifact, asymmetric patient positioning, scaling artifact, off-peak acquisition, and prior cerebral infarct. Motion artifact is a common pitfall. Because of the resultant blurred activity, both qualitative and quantitative assessment may be affected. Motion artifact is common in patients who are unable to lay still. Anxiolytic medication may be helpful in patients with anxiety or discomfort. Since repeat imaging may be helpful in some cases, it's important to review cine images and for the technologist to be aware of this potential pitfall. Another potential issue is asymmetric positioning, or lateral head tilt, and these may produce an asymmetric appearance of the basal ganglia, which can mimic a positive study. Additionally, forward head tilt may result in a loss of activity in the putamen on some axial images, as the putamen is projected onto another axial image. Appropriate positioning is important. If positioning is thought to be responsible for the abnormal appearance, manual or software-assisted manipulation of the images and review of all axial images may be helpful for clarification. If the salivary glands are included in the field on post-processing images, intense salivary gland activity may produce the appearance of relatively decreased basal ganglia activity. Knowledge of this potential issue and review of images to assess for salivary gland activity inclusion may be helpful to avoid this pitfall. Another pitfall is off-peak acquisition. Off-peak acquisition is a classic and avoidable pitfall in nuclear medicine. If acquisition is incorrectly set for technetium-99m, for example, which has an energy of 140 keV, instead of I-123, which has an energy of 159 keV, the images may be compromised and may appear abnormal. An example of this is provided in the article. Prior striatal or basal ganglia infarction may produce a false positive study due to the abnormal loss of the dopaminergic neurons. Correlation with MR imaging, or CT imaging if obtained, can be useful to assess for evidence of prior infarctions that can cause this appearance. This is one issue that can cause activity loss that doesn't follow the normal posterior worse than anterior pattern. It's also important to note that Parkinson plus syndromes, including, for example, dementia with Lewy bodies, may have a more subtle appearance and may have earlier involvement of the anterior striatum rather than the classic posterior to anterior loss seen with Parkinson's disease. Up to 10% of patients with dementia of Lewy bodies may have a negative study early in the disease course. When reporting dopamine transporter studies, it's recommended that the report include technical details, including radiopharmaceutical dose, the time of acquisition, and any known technical limitations. It's recommended that findings should include the presence of normal or abnormal activity, and whether abnormal activity is unilateral or bilateral. Information including which side is worse and the pattern of activity loss is also suggested. It's recommended that the impressions state whether or not there's evidence of dopaminergic loss and whether the findings support the diagnosis of Parkinsonian syndromes. In summary, dopamine transporter SPECT can cost-effectively improve diagnostic accuracy, with reported sensitivity and specificity greater than 90%. Normal findings include bilateral, symmetric, comma-shaped activity overlying the striata, with activity that should be intense and distinct in comparison with background brain parenchyma. Abnormal studies show decreased uptake, and this can be either asymmetrical or symmetrical. Initially, activity loss typically affects the posterior putamen, resulting in an oval or round region of activity instead of the normal comma-shaped activity. With disease progression, activity loss within the anterior putamen and caudate can also be seen. Since approximately 50 to 60% of dopaminergic neurons are lost in patients with symptoms, the imaging findings in symptomatic patients with Parkinson's disease are generally not subtle. Parkinson plus syndromes may not follow the typical posterior to anterior pattern of activity loss, and findings in these patients may not be as apparent. Additionally, potential pitfalls or issues confounding interpretation include motion artifact, poor patient positioning, scaling, off-peak acquisition, and prior cerebral infarct. I'd like to thank Dr. Megan Mercer and colleagues for this article, a practical overview of I-123I-Ioflupane imaging in Parkinsonian syndromes. And I'd like to encourage you to review this article for yourself and to subscribe to and listen to other radiographic podcasts. Thank you all for listening. I hope you found this summary useful.